Welcome everyone, and thank you for joining today's webinar. My name is Suzanne Walker and I'm the Senior Marketing Manager for Public Health here at Jones & Bartlett Learning. And today I have with me Richard Skolnick, author of Global Health 101, which just came out in a new edition a few weeks ago. Today, Richard will broadly explore women's health issues and what can be done to address issues that go beyond reproductive health. He will also comment on women's involvement in global health efforts and how we might enhance the training of women leaders in global health. So now let me tell you a little bit more about our presenter, Richard Skolnick. As I previously mentioned, he's author of the best-selling text Global Health 101, and he has a great deal of experience, which you can read here on the screen, having worked in positions at the Population Reference Bureau, World Bank, and Harvard's AIDS treatment program. He has also taught more than 40 global health courses to graduate, undergraduate, and business students at George Washington University's Milken School of Public Health and the Yale School of Public Health and School of Business. And with that, I'd like to turn the presentation over to Richard.
Suzanne, thank you very much for the very kind introduction and for putting the webinar together. And my thanks as well to all of those who are participating in the webinar. I'm very honored by everyone's presence. I always learn a lot, both from preparing for these and from the comments and questions that arise, and from the substantial number of participants who are kind enough to share ideas with me after the webinar is over, and often for many years to come. And I invite, of course, everyone who's participating to keep in touch, again, with the hope that I might learn as much as possible from all of you. Second, I want to remind you that my comments are going to be very brief and in many respects kind of stylized. Nonetheless, I hope that you will find them to be helpful to your own studies of global health and or teaching of global health or practice of global health. And I should say I'm also very touched and honored that a number of friends and people from places I've lived and worked are participating in the webinar today. Third, I approached the topic with considerable humility, knowing that many of you and many others are far more expert in women's health matters than I am. Nonetheless, if I might say in a somewhat humorous vein, my friends, who include some of the leading authorities in the world on women's health, have now taken to introducing me as the leading authority on paraphrasing the leading authorities, and I hope that I'll do a good job of that today and perhaps even a little bit more. So let's begin by first looking at the objectives, which I hope when you leave today, you'll have a little bit better understanding of the burden of disease among women globally, some of the measures that might be taken to address them, some additional ideas perhaps about how we might do a better job of teaching women's health. And I also wanted to comment about discussions that are very much ongoing now on women in the global health community. And finally, I'll make a few comments about how it is that you might find the fourth edition of Global Health 101 hopefully even more helpful to your teaching and learning than the previous editions have been. So Suzanne, if you'd be kind enough to change the slide and go ahead down to the first data slide. Thank you so much. So let's look first let's try first to answer the question, what is it that adult women are getting sick, disabled, and dying from worldwide? For simplicity's sake, I'm going to show slides only by using the World Bank low-income country group and high-income country group, but I'm going to make some comments, of course, about all four country income groups. When we look at the left side of the slide and we look at low-income countries and women age 15 to 49, low-income countries on the left, high-income countries on the right, with the data, of course, being taken from the Institute of Health Metrics and Evaluation Burden of Disease Studies, what we see, in a very disappointing but understandable way, is that there remains a very large, what we used to call group 1 burden among women in low-income countries in this age group. There's still a remarkable preponderance of communicable diseases, maternal causes, and maternal causes, as we see in the top 5, in fact, and then again in lower respiratory infections. By contrast, when we look at the high-income countries, as we know and as we would expect, what we see in this age group among women is not a single communicable cause and not a single maternal cause at all. If we had included lower middle income and upper middle income countries, we would have seen some reflection of the low income countries and the lower middle income countries, but a pretty rapid transition as we looked past the upper middle income countries, who would increasingly look more and more like the high income countries. So one clear message from this is, certainly when it comes to low income countries, we continue to see a very substantial burden of group 1 causes. And yet, when we look at the other country income groups, we need to understand and appreciate very well that women globally in this age group are dying from a range of causes. And again, as we might expect, the higher the income group, the more those causes will reflect the same kinds of conditions that affect women in most of the countries from which you all are coming. So let's go to the next slide and look at the next age group, if we might. And this is leading causes of death for females 50 to 69, again, low income countries and high income countries. And here what we see when we look at the low income countries is there continues to be an important share of the deaths for females these ages in low income countries that come from communicable causes, including tuberculosis, lower respiratory infections, and malaria, and even diarrheal diseases. By contrast, again, when we look at the high income countries, what we'll see is an overwhelming share of the deaths are coming from, as we would expect, again, non-communicable causes. If we again here too, what we would find would be a little bit different. If we had included lower middle income countries and upper middle income countries for this age group, what we'd almost certainly find is a more rapid transition toward the pattern of deaths that we see in high income countries, with the communicable causes remaining predominantly important, really in the low income countries and among poorer people in lower middle income countries. But again, a fairly rapid transition after that to a pattern of deaths in women this age that looks more and more like the pattern of deaths in high income countries. So let's go on, Suzanne, to the next slide, if we might. And let's look at DALYs instead, disability adjusted life years for females ages 15 to 49. And here, again, for low income countries, what we see is, in some respects, the DALYs reflects just what we would expect because we know of the importance of communicable causes and maternal causes of death in this age group. And yet, it's really important to understand as well that when we're looking at DALYs instead of deaths, we see the remarkable importance of mental health disorders shown here through depressive disorders and anxiety disorders. We also see neuromuscular and skeletal disorders when we look at low back pain. And we also see, as we know very well, the importance of nutritional causes for women in low-income countries. And in this case, of course, it's dietary iron deficiency and in some respects undernutrition, rather than the nutritional causes that we're going to see in higher income groups that relate more to what we might call obesity and overweight. By contrast, when we look at the high income countries, again, there are no real surprises here in most respects. But again, it's very important to note that when we look at DALYs for this age group instead of deaths, we're looking at a really important disability adjusted life years that relate to headache disorders, neuroskeletal disorders, mental health disorders, and the high income country drug use disorders as well. When we look at gynecological causes, we have to remember, as all of you know much better than me, that maternal causes aren't just you die or you live. There are many morbidities associated with childbirth, and there are also a wide range of gynecological causes as well as sexually transmitted infections. Let's go to the next age group, next slide, if you would, Suzanne. And when we look at disability adjusted life years for females 50 to 69, what we're seeing here is, again, the real value, in my view, of the DALY, and that we note that there are a range of causes of DALYs, both in low-income countries and high-income countries, that don't show up in deaths. But again, what we want to see is what we're looking at in important ways is neuroskeletal and neuromuscular disorders. And we're looking at cancers in a very substantial way here that do show up in deaths, but also for people who are often treated for them or disabled by them. They're showing up in important ways in high-income countries, certainly, and in low-income countries as well. And we also see, again, the importance of mental health disorders that don't show up so much in deaths, though they are associated with more than we usually think. But again, they come out very well when we were looking at DALYs instead of deaths. So Suzanne, if you would go on to the next slide. Please go ahead. And here, I'm sure all of you are very familiar with and work a great deal with both determinants of health, social determinants of health, and risk factors. And here, when we look at the leading risk factors for deaths for low-income and high-income countries, what we see is not particularly surprising. What we're looking at, though, and what we have to remember is the remarkable importance of unsafe sex, not only in low-income countries, but also in high-income countries, related, of course, to HIV/AIDS in many respects, but also to other sexually transmitted infections as well. We have to look carefully and take important account of high blood pressure is a very substantial risk factor for the growing burden of non-communicable diseases. Environmental causes, of course, remain very important, not only in low-income countries, but also in some of the other country income groups as well. And alcohol use, of course, and nutritional causes remain very important. So on the one hand, when we look at low-income countries, what we're going to see is risk factors that in some respects relate to the communicable causes and maternal causes we looked at for deaths, but they go beyond that as well. When we look at the high-income countries, here what we see is the overwhelming extent to which nutritional causes are important, and these relate largely to obesity, overweight, high blood pressure. But also we see in these countries the extent to which in some settings women do smoke, do consume alcohol, often in excess, and the importance of substance abuse disorders as well. Please go ahead to the next slide, Suzanne. And I'm not going to comment much on this. There are no real surprises, I think, in this. And again, what we want to look at with respect to the older age groups who will die more and more of cardiovascular causes, diabetes, et cetera, we have to take very important account, of course, of nutritional causes. So let's go on, Suzanne, to the next slide, if you would. Here, when we look at the risk factors for DALYs, what we're looking at is not so different than the risk factors for deaths. But here, when we're looking at the low-income countries, it's remarkable the extent to which unsafe water and unsafe sanitation continue to be important. But here I also want to point out that despite the fact that undernutrition remains such an important concern in low-income countries and lower middle-income countries, we see here that it's still a very important risk factor for disability-adjusted life years, as I mentioned earlier, for this age group in low-income countries with respect to iron deficiency. But at the same time, the nutritional transition is making high body mass index an important concern, not only in higher income countries, but also low income countries as well. And all of you know, I'm sure better than I do, the important extent to which there are now in the world more people who suffer from obesity and overweight than there are people who suffer from undernutrition, including among females. Let's go on, Suzanne, to the next slide, if you would. And when we look at the older age group, again, we're looking to a remarkable extent at risk factors that relate to nutritional causes. But again, we see particularly for high income groups, the importance of smoking and the importance of alcohol use as well. And environmental causes also remain very important risk factors for disability adjusted life years in all these age groups for women across the range of country income groups. Suzanne, if you turn to the next slide. So I want to, in a very brief and very stylized way with some apologies, mention what I see as some of the key takeaways when we look at the leading causes of death and the leading causes of DALYs among women in the age groups 15 to 49 and 50 to 69 globally, and especially when we look at them across country income groups. One is as my friend Elaine Murphy said in a very important article she wrote some years ago, being born female is dangerous to one's health. The extent of that danger varies, of course, by country. It often, but not completely, varies by country income group. And in some respects, it probably varies most by the extent to which countries are committed to the well-being of their women and equality between women and other groups of people. But being born female is dangerous to your health in many, many ways, and we have to constantly keep that in mind as we think about our work and our studies of global health. Two is women's health, as you can see, goes way beyond reproductive health. This should be obvious, and it is obvious, I'm sure, to all of us. And yet, when we look at a lot of the literature, especially the literature related to teaching global health, what we find is that literature tends to focus only on reproductive health and often makes very little mention of the broader causes of death and disability adjusted life years among women, both globally and in particular with respect to poorer women, for example, in lower and lower middle income countries. If one cares about enabling better health among women globally, then it is essential that we continue to focus on reproductive health, which remains such an important cause of death and disability in women, particularly in low and some lower middle income countries. And yet, if we want to enable better health globally among women, we must go beyond that. And we must, I think, ensure as teachers that we have a better understanding of the causes of death and disability among women. And we do a better job, perhaps than I've done before, in trying to ensure that we impart that to our students and help them to have a broader view as well. My third comment isn't meant to be cheeky or snarky so much as to just say, if we care about the well-being of women, we must take a very broad view of their health. And just as we would do more broadly, use the best data we can in understanding what are the causes of death and disability adjusted life years among women. How do they vary by country income group? How do they vary by region? How do they vary by place across and within countries? How do they vary within different groups within countries as well? All of this is going to be essential if we're going to get a real understanding of what are the health issues that women face, how do they vary across different places, and what might be done to enable better health among women. And finally, as I'm sure all of you do very well already, it's important for us to take a gendered approach to global health. I visited a country once when I worked in South Asia. I visited a country many times, but on one occasion when we were working on a tuberculosis control program, I asked the people at a local clinic why no women were on the registers as having been either tested for or diagnosed with TB. And the clinic workers assured us that there were no women with tuberculosis in this very substantially sized province of a very substantially sized and very important country. This was for real. I'm sure all of you have seen this in different settings. But the point is, we need to take a gendered approach. We need to say to ourselves and to others, but perhaps when we come back, we might discuss with you further this particular question. And maybe in the interim, there are measures that you might take to see whether or not any women are being missed, etc., either in being tested and or diagnosed and or treated for tuberculosis. And one will find, of course, really different responses when one looks for and asks the right question rather than one taking too broad a view. Suzanne, if you would go on to the next slide. So this is also, of course, very stylized, and I beg your forgiveness for this. And the first line should probably say, so what can be done to enable better health of women, particularly poor women in the poor country groups, and particularly marginalized women in all country groups? Again, clearly, and I'll start at the bottom. Among the poorest women and the poorest women, both in poor countries and in lower middle income countries, there remains a gigantic unfinished agenda of communicable and maternal causes. Maternal death, HIV, TB, malaria, FGM, intimate partner violence remain very, very important causes of both death and disability in these countries. They are among the leading causes, and it remains important that we understand them, understand what might be done to address them, and do a good job of trying to learn them if we're students and enable our students to learn more about them and what can be done about them if we're teachers. But at the same time, as we've seen, it's very important that we go beyond that, both not only for women in higher country income groups, but actually for all women in all country income groups. We need to understand, and I apologize, this should really say non-communicable diseases, or at least cardiovascular disease and diabetes. But we know that not only in the high income country groups, but in all country income groups, there's now a predominance of disease. We know now that outside of the lowest country income groups, the predominant causes of death and disability adjusted life years are non-communicable rather than communicable. They're non-communicable rather than maternal causes. And it's essential if one wants to enable better health of women globally and in these countries, that one pay increasing amounts of attention to a kind of gendered understanding and approach to non-communicable diseases, including cardiovascular disease and diabetes, to cancers, and of course to mental health concerns, which are extraordinarily prominent, but even more prominent among women than they are among men. Even though this is brief, I think it's important to say that I would encourage students and practitioners to think about these in terms of what can be done in the short run, the medium run, and the long run. I would certainly encourage us as teachers and those who are practitioners to think also about the determinants of health, the social determinants of health, that are so important, especially with respect to the place of women in different societies and the relationship between their place in those societies and the health circumstances that they face. And finally, and this is something I've tried to highlight in the last chapter of the fourth edition, it's important to remember that especially when we're thinking about the health and well-being of women, we need to be thinking hard about intersectoral approaches. A huge share of the health circumstances that women face in all countries, but particularly poorer women in poorer countries, has to do with access to water, safe water, and sanitation. It has to do with the nutritional status of women. It has to do with the educational achievements or lack of them of women. It has to do with the place of women in society compared to men and their ability, for example, to negotiate with men when it comes to their own health and well-being. And I think it's going to be really important, therefore, given the many factors that influence the health of women and the place that they play in a wide number of societies, and the fact that being born female is dangerous to your health, it's going to be important to take a really holistic view, understand the causes of death and disability among women, think about this, as I said, in terms of short, medium, and long run, think of the important place of social determinants and determinants of health, and finally understand that only a small share of what can be done to address some of these causes sits with the Ministry of Health, and in the medium and longer run, really helping to enable the better health of women will in fact require intersectoral approaches to enable different places to move forward. Suzanne, if you would go ahead to the next slide. So in the fourth edition of Global Health 101, I've tried to go beyond reproductive health. The chapter is still imperfect, and I'm looking forward to the fifth edition already, but I hope that you'll find it more useful than any of the previous editions to your teaching about the health of women that might be done to help women lead healthier and fuller lives globally. As I did in previous edition, I tried to walk learners through 5 questions. What's the problem? Who gets it? Why do they get it? Why should we care, and what can be done? But better than in the previous editions, I've tried to talk about what can be done by focusing on cost-effective, doable, sustainable, and fair ways. I've tried in the fourth edition never to speak about what can be done without highlighting the ideas that these cost-effective, doable, and sustainable approaches must also be ethical and must also be done in fair ways, with particular attention, of course, to marginalized people, many of whom will be females in many societies. I've also tried better in the 4th edition than previously, and this I'm reasonably happy with, to embed these efforts in universal health coverage, to heighten the centrality of equity concerns, and to heighten the centrality of taking a gendered approach to all that we think about in global health. And I hope that you'll find that the book this edition will be more helpful to you in these regards than before. I've also writing a number of, I'm just going to say one more word, Suzanne, if I might. I've also writing what basically will be a substantial number of blogs that in some respects will be a little bit like an old-fashioned teacher's manual. So I hope that the blogs will be helpful to you, and that when you look at the blogs, you'll see some ideas, both from myself and from generous friends, about how it is that we might do an increasingly good job, both of studying the health of women as part of our global health studies, and in helping to teach about the health of women to our students. Let me end by just saying a couple of words about women in global health, which is a topic that's much under discussion these days. Everyone in the webinar is keenly aware that while the majority of our students in global health consistently tend to be women, and while there are tens of thousands of women working in global health activities throughout the world, the leadership of many areas of global health continues to be dominated by men. What I've tried to do to help all of our students, including our female students, and sometimes especially our female students, is since the 2nd edition, include 2 career chapters in the book. One of them is called Working in Global Health, and another is called Profiles of Global Health Actors. The Working in Global Health chapter tries to outline for students the global health landscape and the kind of skills, training, experience they need if they wish to pursue further a career in the domain of global health. Pardon me. The Profiles of Global Health Actors, which I've updated now, I've continued to include some from before, but added some new ones. The Profiles chapter is meant to inspire students with very specific stories of actors in the global health arena, but also to give them role models of people that they might wish to be like. And I'm always very heartened when a student says to me, Professor Skolnick, I'm really touched by the profile of Ellen Ogden. And by the way, it was great that you could bring her to guest teach in our class. She is really the kind of person I want to be, the kind of person with the skills, talent, experience, commitment, humility that you've talked about. And I can never thank you enough for helping me to meet her. It's not going to be possible for all of us to help our students to meet some of these people, so I've tried hard to make the profiles come as alive as possible. We've included photos this time, and here you see one of Ellen Ogden giving polio vaccine at a booth in, I think, Kolkata, India. Ellen, in my view, is a saint, and among many saints I know, both men and women working in the global health arena. But I hope that these chapters can be useful to you and save you an enormous amount of time. Before I would meet about 150 students a semester for advising, what I would do is have them read these 2 chapters. I would have them send to me 3 lines about what they think they want me to say about them 15 years from now. I'd have them give me their resume as well, and I'd have them give me 3 questions that are most important, that they think are most important for me to help them answer. I wouldn't suggest that you should do the same, but I do hope that these chapters can be helpful to you. And with respect to our female students, I hope that they can be especially helpful. I've tried hard in this edition to add some additional profiles of women who are leaders in global health work, including Gina Lagomarsino, who heads Results for Development, Eleanor Allen, who heads Water, a very important NGO that deals with water and sanitation, including Ellen, who's headed USAID's polio work for 13 years, Sue Horton, who's a provost at one of the Canadian universities and a great pillar of work on health economics, global economics, and the economics of nutrition. So I think Well, we want to be helpful to all of our students, but I hope we can also be especially helpful to some of our female students who may be impeded by what they see as constraints to their moving forward. But I think that by helping them to gain experiences, understand the landscape, find role models, and link with potential mentors, I'm hoping that we can be helpful to all of our students, but especially helpful to seeing that 10 or 15 years down the road, more and more of our female students will not only be working in global health, but will also be playing increasingly prominent roles in an arena in which an increasingly large share of the leaders are women as well as men. So I can't thank you enough for joining me today. I apologize again that the remarks can only be very brief, but I hope in a small way they've helped you to think a little bit more about what it is that women get sick, disabled, and die from, the areas on which we need to focus to address that, and a few ideas as well about how we might be increasingly useful to our students, both in understanding the health of women globally and to our students in helping them to pursue careers in the global health sphere. So Suzanne, let me give it back to you, and I'm happy to take any questions that have arisen.
Thank you, Richard. We do actually have a question and a comment here, and more questions coming in. The first question is, what are the high and low income countries? I don't see them listed. So maybe you could take a second and just kind of talk about which countries are the high and which ones are the low.
Sure. The World Bank is the organization which is generally tasked with dividing the world up into what we call country income groups. And for a number of years, the World Bank has divided the world into country income groups, 4 country income groups: low income, lower middle income, upper middle income, and high income. Those are based on the per capita income of these countries as updated yearly by the World Bank and published yearly in the World Bank Atlas. You'll see in Global Health 101, in one of the very early chapters, an outline of how it is that these countries are categorized into the 4 groups, and a table that shows you examples of the 4 country income groups. One of the things I've tried to do in this edition is to show more and more of the data by country income group, even as I showed it by region. And I think this is increasingly important because, of course, most of the correlates will be by income group rather than by region, although there'll also be lots of them by region, because in Southeast Asia, there are countries that might be as rich as Malaysia, but countries, for example, that might be as poor as Laos. In sub-Saharan Africa, there are countries as well off as South Africa, but as poor as Chad, for example. And I hope that you'll find that by showing data by country income group, this will be make it easier for you to teach about the correlates between health and income, but also for you to help students identify the outliers. Because at the end of the day, the question is, how can we as country X enable better health among our people as fast as possible, as fair as possible, at least cost as possible, and in a way that is better than one might predict for our country income group. So I hope that's helpful to you, and I hope that you'll find the way that I've handled it in the 4th edition substantially enhances the manner in which it's been handled in the previous editions. Please go ahead, Suzanne.
Sure. I just want to read a comment made by Karen Hendry. Massachusetts chapter of National Organization of Women have taken steps towards passing new legislation regarding free access to feminine hygiene products, Bill H.565, which is proposed to go into effect in August of 2020, will require all public schools in the state of Massachusetts to provide free, easily accessible feminine hygiene products in the restrooms of all school buildings. So she shared that. I don't know if you have any comment to that.
No, I thank her very much for that comment. And of course, it relates in important ways to what goes on in many countries around the world, in which women don't have access to these products at all, in which women during menstruation are sent, like they have been historically in Nepal, to huts to be separated because they were so-called unclean from the rest of society during this period. And I'm sure many of you are familiar with the efforts that a number of people have taken, global health heroes in my view. Particularly, I know some groups in India that have been working hard to develop very low cost but hygienic products for women in ways that will make them vastly more accessible, and at the same time to reduce the stigma that's associated with both the period of menstruation and with these hygiene products themselves. So I thank the person for this thoughtful comment, which certainly relates in extremely important ways to the well-being of women throughout the world.
All right, I have another question here. This is from Natasha Poggio. In developing countries, many women have still limited literacy skills and access to proper information about their health. What are the ongoing efforts to communicate global health issues to audiences that lack access to information, and how are those efforts being measured to improve the understanding of information when that is available?
So first of all, let me thank Natasha for her very thoughtful question. Second, let me thank Natasha, who very kindly allowed me to profile her in the 4th edition. And I'm sure that you'll find the profile of Natasha to be one that's very inspiring and very interesting. I tried hard in the 4th edition and in the previous editions as well to show people that you don't need to be a healthcare professional to have an important place in enabling the better health of people throughout the world. Natasha is a graphic artist who's been deeply involved in a number of countries in trying to enable better health messaging, particularly with respect to people who may not be literate. Some of this has to do with I think, tuberculosis in some countries, some with good health and hygiene. I know she's also done some really interesting work on prosthetic devices and communicating health messages about them. So Natasha's question reminds me of repeating over and over again the important message that there's a role for a wide range of actors in global health. And in fact, the health of people globally cannot be improved without actions across a range of domains. I'm not at all, let me say this. Understanding a range of health issues and what might be done about them, particularly in low literacy settings, of course, is enormously challenging. And I've always felt, including during my 25 years as a practitioner, that this was an area to which insufficient attention was being paid. I think in the last 20 years, there's been some much better progress in messaging about health, particularly in low income and low literacy settings, and particularly among women. And among the better examples of them, I think, have been some of the efforts in trying to achieve better supplies of safe water and improved sanitation in countries, for example, like hand washing in Senegal and total defecation, eliminating open defecation in Indonesia and Bangladesh. You could argue, and one might not be happy with a few things that happened, for example, like some shaming in Bangladesh. But my sense is that people have a better understanding now that they didn't have when I began in the development business a long time ago about the importance of health messaging, the importance of building of communities engaging themselves around these health messages and community leadership. And I think there's been some real progress. Polio is another interesting case, and there's some really wonderful case studies of vaccine hesitancy in Nigeria and India, for example, in marginalized communities, and how it was, what people learned about the causes for such hesitancy, and how people began to get a better grasp on the kinds of health messaging that was needed and who needed to be involved in it if those hesitancies were to be overcome. And indeed in India, North India, and in northern Nigeria, they were. So I can only say Natasha is a real expert in this field. Her work has been really important. I encourage you to look at some of it, and I encourage you to think broadly about the many different areas of global health skills which can play an important role in helping to improve the understanding that people have in different countries of their health circumstances and how they might might be improved. Please go ahead, Suzanne.
Sure. Well, this one comes from Catherine Jacobsen. She was wondering if you would like to mention a few of your favorite global health teaching resources that are freely available to instructors online, such as World Bank, IHME, or other sites.
So Catherine is a dear. I'm touched that my friends would be here and grateful that they would raise such thoughtful questions. Catherine's a dear friend and a professor at George Mason University, who's done very much good writing on global health, and I commend you to look at Catherine's work, for which I continue to have a great appreciation, and I'm very grateful. Catherine's always helping me to do my own work as well. Almost everything that one needs in terms of data, and much of what one needs in terms of extra textbook resources is available online. In terms of data, I think almost all of you will be familiar with the work done on the burden of disease by the Institute of Health Metrics and Evaluation. What they do is they update this data regularly, and they have really what has to be considered, I think, an extraordinary website, which is called Compare, to which you can go and where you can look at the burden of disease by country income group, by different regional groupings, by social development index, etc. And I always try to ensure that from the very beginning of my classes, my students are great gurus of how to make very good use of the interactive website of the Institute of Health Metrics and Evaluation, so that they can understand as well as possible how the burden of disease varies across countries, across regions, across country income groups, across sexes, and across age groups. I think they've made an extraordinary contribution. The only thing you need to be aware of is they update it so constantly that if you publish or teach with data one day, a few days later, one piece of data won't be the same. But it's an extraordinary resource. The World Bank is more or less the keeper with the World Health Organization and UNICEF now kind of jointly of the basic data on most key indicators in global health, though WHO will have a wider range of indicators that relate to health systems. And the World Bank, you just go World Bank data, and you can go in and get basic data on infant mortality, neonatal mortality, infant mortality, maternal mortality, ratio, neonatal mortality, infant mortality, etc. And I can't encourage you enough to make use of the World Bank resources and ensure as well that that your students do so. And you'll see if you use Global Health 101 4th edition, the data overwhelmingly is taken from both the IHME website and the World Bank data sets as well. But there's also, I wanted to make a comment about a couple of other resources. There are really a wide range of resources. The Gapminder resources that Hans Rosling did before he died and that his family has continued are extraordinarily useful for your students. And one that I began using more a little bit recently is a photo bank of, I think, 36,000 or something photos taken all around the world that illustrate critical issues in global health and how they look in different places. What does the lack of water look like in some settings? What does poor sanitation look like in other settings? How does undernutrition manifest itself in still other settings as well? That's a fantastic resource, as well as, of course, is the short videos that Hans did, which I think can be an enormous inspiration to your students. I knew Hans. He was a complete, absolute genius, a really great man, of profound intellect and a great sense of humor. And I can't recommend enough the gapminder.org videos. And a fourth site I want to recommend, and we have a list of global health resource sites available to you if you use Global Health 101 4th edition, is Greg Martin's YouTube videos. Greg is a dear friend and a person also of exceptional competence. He's a physician public health specialist who works with the Irish Public Health Authorities, though he's from South Africa. Greg has a YouTube channel with 47,000 subscribers. And Greg does almost weekly videos that are very cleverly done. They're very brief. They're very insightful, and they can be a real adjunct to your teaching global health And overwhelmingly, I think your students will really, really appreciate them. There are many more resources. I thank Catherine for asking me to mention them. And again, I think you'll find the resources associated with Global Health 101 will point you toward a number of resources that I've certainly felt were very helpful, both in my work as a practitioner and in my work as a global health educator. Suzanne, please go ahead.
Okay, Christine Malinowski asked, does the new edition discuss creating global health study abroad programs ethically and using different competencies like CUGH to make sure that they are sound and ethical from both the host and participating countries?
So this is a very good and a very important question. And the answer is not very much. What I've tried to do is outline the kind of skills, experience, the kinds of education, knowledge, education, skills, and experience that students need to do to work in global health. I've tried to outline the kinds of organizations with which they need to work. I've tried to outline the kind of, when I talk about skills, the kind of style and personal attributes that one needs to have if one is to succeed in a career in global health. And I've tried to ensure that the people I profiled manifest those. But I really felt as I went through this that there were other resources that could provide answers to the thoughtful question just raised better than I could, and that it would be more prudent for the students and faculty interested in those to look in those areas for the kinds of information that can help people to ensure that the experiences in which our students engage are always carried out in the most ethical ways. I'm actually going to Rotterdam next week and have been asked to speak at Erasmus Medical College, and for the 10th anniversary celebration of their global health program. And I encourage you to look at their program because it's one of the most elaborated and thoughtful programs I know for trying to ensure that those medical students who participate in their global health minor actually have engaged in ethical experiences overseas with a number of partners that they have. Rebecca Badgett from Emory will be coming, and they have a very elaborated program as well. But when I speak in Amsterdam, I'm actually going to focus on what healthcare professionals should know about global health and why they should know it, and the kind of attributes we want them to have and how this knowledge would play into it. But actually then turn it over to my colleagues from Iran, from Erasmus, and from Emory to speak much more. So it's a thoughtful question. It's fundamental. I point it out in the book, but I think there are better resources than I could provide. And I would encourage you to turn to those as you think about developing those experiences for your students or helping them to undertake them. And I'd be happy to add additional resources to the website soon for those so interested. But I think there are others who can do this better than me, and I would point you toward them. Please go ahead.
There's and I'm not 100% I'm clear on it. It's from Mohammad Rezak. There is a suspicion on NGO activities related to women's health in developing countries, which is a barrier for healthcare providers. Do you have any suggestion to reduce miscommunication? And they add a apology. Sorry if this goes beyond the scope of the chapter.
No, not at all. So, the place of non-governmental organizations varies considerably by country. In some countries, non-governmental organizations are essentially owned by government, and government doesn't really want them to be anything other than that. In other countries, non-governmental organizations have a role almost as large as the government in the provision of healthcare services, such as, for example, in Bangladesh. There's always been some important tensions between the government and these NGOs in Bangladesh, like BRAC, and yet the NGOs there remain, I think by all accounts, exceedingly effective, exceedingly thoughtful, exceedingly evidence-based, and exceedingly interested in being knowledge-based and having their work independently evaluated. And then there's kind of everything in between. I think what's probably most important is to ensure, as far as possible, given the way that governments work and their varying degrees of openness and autocracy, to try to be as sure as possible that NGOs enjoy the appreciation and respect of governments, that their role is clear and agreed, that the communities with which they work see them as essential partners, and that they work as far as possible in partnership, in conjunction with these communities, in ways that are evidence-based, in ways that are ethical, in ways that are fair, and in ways that take account of these very different and sometimes very trying political circumstances under which they work. I think NGOs also have an obligation, even if they're small, to try to be, of course, effective and efficient, and to try to be cost efficient in their work. That's not always easy. It's not always easy in any setting in which human resources for health are limited. It's even harder in places where they're extremely limited. But I do think there's an important place for NGOs. In some places, their role is extraordinary, exceptional, and highly impactful. And in most places, they could probably play an even more important role. But this will be challenging to a variety of degrees in different settings. Please go ahead, Suzanne.
Okay, we have one final question here. Do you have any suggestion about hands-on learning activity off campus that our global health students can do in our community, Lynchburg, Virginia, in regards to global health? Either raise awareness or educate community members, including young students. Thanks.
Yeah, I mean, so I've always said that the health of everyone everywhere, that the health of anyone anywhere is the health of everyone everywhere. And certainly in an age that is as globalized as our own, we understand that whether it's bioterrorism or it's antimicrobial resistance or it's emerging and re-emerging infectious diseases, communicable diseases that are going around, the threats from vaccine hesitancy, the extent to which high burdens of disease can be destabilizing of different places, their budgets and their future. I mean, these are all really important, and they're really important to everyone on Earth, not to mention climate change, for example, and the threat that it poses potentially, and actually already manifest in some places, for changing health circumstances, possible migration, possible changes in patterns of disease. There, certainly with respect to the United States, which is a large, somewhat, if not very insular society, in which the majority of people have never traveled outside the country, I think we would be in a much better place if our citizens were more enlightened about the importance of global health and why it's both in ethical terms and in health terms not okay that 5 million young children a year should die in the world, as well as why we ought to be very worried about and very concerned about the new report that says not a single country in the world is prepared to deal with a pandemic should one arise anytime soon. So I think there's an important role for students to play. And I lived in Reston for 42 years, by the way, for the questioner. And Catherine lives in Northern Virginia as well. I think there's a very important role to play for students in advocating not only within the universities, which they often do and often do quite well, but indeed, as the questioner mentioned, taking their advocacy outside of the university and working with the community as well to create an array of events that will help community members, particularly in places that are lovely towns like Lynchburg, but may not have so much exposure to global health ideas, so that folks there can understand why the health of people throughout the world is so important to them, and why, as American citizens and voters, they should be doing what they can to encourage the development of new diagnostics, vaccines, and technologies to help the health of poor people in poor countries, to enhance the resources and the skills available at CDC and other places, for example, so that the U.S. is ever more prepared for dealing with emergencies, to encourage the development of new antibiotics in ways that are important to all of us, but not going to happen so readily under the existing market arrangements. So I hope those will happen. I encourage students to do it. If I can ever be helpful, the students or the faculty are welcome to get in touch. I've moved to a very small state that has the worst state of child welfare in the United States. That's New Mexico. And I'm trying hard myself now, and in conjunction with some others, to engage in advocacy that might enable people to pay more attention and better attention to the health and well-being of children here, and to the vaccine agenda as well, where New Mexico, by the way, is actually not so badly off, except in a few pockets of remarkable vaccine hesitancy, schools where fewer than 50% of the kids are immunized. So I think these are wonderful, and as they organize around the university, I hope they'll take their work outside as well and do what they can to help America become a much more enlightened society when it comes to critical issues in global health and why they are so important to us, even if we don't know it. Suzanne, is there anything else? I'm happy to stay if I haven't given too bad a headache to people already.
Okay, well, I think that's about all the time that we have for questions today, Richard. But I on behalf of everyone, I want to thank you for sharing your expertise and sharing with everyone this very informative presentation today. And with that, I end today's webinar. Thanks everyone for coming.